I've actually did you see that thing with the Argentinian minister on Zoom?
No. What was that?
Okay, that's one you have to look up because I can't describe it. It's made the news. It's easy to Google.
Right.
Anyway.
Okay.
One thing then look up. I'm looking up.
I know we all sort of like that. Right, everybody, welcome back to another bite-sized webinar. We were absent last week. We are back, and as you can see, I have the regular duo on the panel, Carl Horton, Will Murphy, and this evening I'm pleased to say that we are joined by the fantastic Danny and Steve from DSD. Hi, boys.
Yeah. Hi there. Okay.
Thank you very, very much for joining us this evening. We're all really excited to have a chat with you. I think I will go easy on the boys and I'm going to interrogate Mr. Murphy first. Mr. Murphy, tell us how your week has been.
My week has been good. Where am I? Oh, I've lost. Where's everybody gone?
Your marbles.
I've lost my marbles. You disappeared off screen because somebody's trying to call me.
We can all see you.
There I am. It feels like I haven't had a weekend because I went straight from finishing my week's work to tutoring on the FGDP implant diploma course. So it was literally went very well, actually. Yeah, it's good. It's obviously been pretty heavily interrupted. But and we moved venue. You know, we've been a little bit nomadic because once upon a time it used to be held at the Royal College of Surgeons in central London, which was very nice to swan around there. But then they're refurbing the whole place, so then we moved down to George's, and then for the last unit, actually, we were over in Kings, which is sort of Denmark Hill over that way. So anyway, the facility is great. We were doing lots of practicals on sinus lifting and block grafting. So it was good. Yeah, pretty full weekend. And we were able to get out and about, you know, in London a little bit. Obviously, things have changed quite a lot now. But yeah, so it was good. I think the cohort's got one more unit. So that's supposed to be later on in the month. So I'm not quite sure how that's going to work out. But I think the educational facility is fine. It sort of lends itself well to, you know, education and social distancing. So that'll be the last one. And then some of the lucky cohort are going to do their exams. Ooh. And then it was back to work on Monday and, you know, more, you know, you do feel a little bit robbed of your weekend. You know, normally I like to have a bike ride and a couple of beers and a glass of wine and you know, just sort of relax a little bit. So it was just straight back into it, you know, more of the same, more implants, more surgery.
So look out this weekend then. Is that what you're saying in the Murphy household?
This weekend, yes. I bought new wheels for my bike and I'm going to give them a test run tomorrow morning.
Oh, good man.
What have you got? What wheels have you got?
I've decided to go carbon and tubeless.
Ooh.
So a bit like a sort of car tyre. So there's no inner tube.
Yeah.
So there you go. We'll give it a go. I'll probably have a puncture within 5 minutes. And be stranded roadside. So have you seen me roadside, anyone?
I'd come and pick you up.
Just put a beacon on my Strava. I'll run past you and help you out.
Thanks very much. Most kind.
So, Will, with the up and coming exams, how do you think that will take place? What sort of format do you think it might look like?
It's a good point, Kate. It's going to be online, actually. So normally the format would be a Viva presentation where you present your cases. So the candidates have 4 cases that they've done themselves, and we've taken them through every stage. So they have to tick off things like a full arch and a bridge and an aesthetic case and another case. And then there's some unseen cases that they'll have to do. So they'll be presented with some x-rays or some scans, given a certain amount of time to look them over, and then they'll just get some sort of routine questioning just to check that they can treatment plan, just know all the basics, you know, on the hoof really. But during the 2 years, they've been assessed on their practicals. They've probably had about 15 assignments to do. So it covers a real broad span.
Yeah.
Ticks all the boxes.
Fantastic. And Mr. Horton, how's your week been?
Same as Will's, but just slightly different. So yeah, was it a Saturday and a Sunday? Did you do both Saturday and Sunday? Yeah, I thought you'd had it a bit harder.
Yeah, it was the full.
I was sat there Sunday thinking, "Oh, poor Will."
But he's there in a plume of pig's jaw dust, you know.
Yeah, it was funny enough. It was the same on Saturday. We were doing the West Midlands one on the fresh cadavers, but not the advanced course. So it was the sutures and flap design and placing a couple of implants and just getting the real basics sorted out.
Oh, nice.
But that was sort of interesting. The lengths that they've had to go through to allow us to do the course. So it was respirators. And I'm not knocking the people that are trying to run the course.
Yeah.
But they've had that insistence from the university because those cadavers can pass on COVID. But they've actually been COVID tested, the cadavers,
Really?
and everything else. So it was, but it's great. It's such a good day. I get a big buzz out of it. I'm sure you do too.
I do. I love it. Yeah.
Yeah, I absolutely love it. And I get a bit jealous because I want to get in there and do a little bit of work myself. Which is, it's not the idea of the day, is it? It's supposed to be helping these guys along.
Yeah. Where's the venue?
West Midlands Teach Centre, Coventry, Walsgrave Hospital at the university side on there. So it's a fantastic venue. They've got all the facilities, the cameras, the microphones. But at the moment, unless you ask, you can't video things. Because of the identification aspects and consent. Yeah. But if you ask them in the first place, they'll set that all up. But it's good. Again, social distancing and all that sort of stuff. So just making sure that everybody was safe, doing it in a safe environment. And the feedback's really good. I like that centre. I think they've got it done quite nicely.
Oh, good.
So that was that. We had an immediate loaded case last week. Which we've been building up to, so that took a bit of organising as well, just getting everybody on board, and that went well. Some new techniques.
Was that
got a question for you, actually, Will. Got a little question for you. I've been told that scrub brushes are no longer that effective, and actually you should be just washing your hands with either soap and water or Hibis scrub. And is that something that you do, or you don't? Are you using scrub brushes, or a bit of both, or whatever you've got on stock? Or
do you wash your hands?
Yes,
yeah. You wash
on
your
the
hands.
occasion, yes, I do. On now and again. Do you know what? In some of the venues, they have little individual brushes with a bit of sponge on one side and a bit of nail brush on the other. And in others, I just wash my hands as normal. I think by and large, and I've heard cases for and against.
Yeah, haven't they? Yeah.
Whether the actual scrubbing with a brush on the skin can bring whatever out to the surface. I believe that was an argument I heard about it. So, I don't know whether there's any hard and fast rules on it, is there?
No. I just thought I'd ask you and see what your thoughts were. Well,
see how I dodge it and kind of.
Yeah. Do you know what?
Very good.
Fudge over the whole thing.
My response was as political as yours.
Yeah,
I wasn't quite like Trump. It's false. It's totally false. It's corrupt. I shouldn't go down that road, should I?
Yeah. Let's leave the politics.
Yes.
Yeah.
So Steve and Danny, I actually text Will this week, and I think actually I have formed a boy band, because my text to Will was, "We've got the DSD boys," and when I reread my text, I thought, sounds like a boy band, doesn't it?
Yeah. Sing us a song, lads. Come on.
Yeah.
Part of the boy band.
It's like an audition.
Absolutely. Now, I know you are part of a fantastic team, because obviously we got the other people working with you, and I want to do a shout out to Dave, obviously, who I speak to. But boys, honestly, thank you so much for joining us. We were hoping you could give us some kind of insight into, obviously, what you guys do on a daily basis to help these two implantologists with their lab work. Will, I don't know if you do use DSD, but what I'm actually meaning by this is that these guys obviously place implants. I want you guys to tell everybody that's listening your part in the process of restoring implants. And also, if you could give us an insight of what lockdown meant for you guys.
Right, yeah. Okay, yeah. Well, obviously we're DSD. DSD stands for Dave, Steve and Danny. I know they got DSD as the digital small design, but we didn't roll it from there, I promise.
They haven't sued you yet.
No, they haven't yet, no. I don't think they've heard of us yet. We keep quiet. We're based in Birmingham in the Jewellery Quarter. We've been in this premises for about 5 years now. This is our 5th year, isn't it? Yeah. And but Steve's obviously been doing the job 29 years. I've been doing it 17 years. And we set up this lab to move forward. So obviously we do in-house printing. We have 2 CAD/CAM machines. We use Dental Wings and ExoCAD. And then we can obviously receive intraoral scans, which Steve, you do.
Yeah, we've received from sort of Trios and well, all of them really. Yeah, basically, iTero, you know, any intraoral scans and you bring them in, and it's a new way of working. It's an interesting thing. You know, we embrace it. There's lots of things to learn digital.
One of the things I'm going to ask you is, because sometimes we get patients watching these videos, or not patients necessarily, but people that aren't dentists. Yeah. So when you say you've got the CAD/CAM machines and the intraoral scanners, I'm going to start basically and let you take over. So what you mean is that when the dentist has a patient that comes in, rather than using the silicone or the putty or the pastes that they used to use, they've got this little camera device that they can take an image of the tooth that's been made ready for a crown or the implant with a little part in it. And then that gets, as if by magic, emailed to you guys rather than sent through the post, and then you guys work your magic by doing what with it? What happens then once you get that little email file?
Yeah, what we get it through an inbox, and then basically we put it into our system. We check that it looks okay, everything's all right before we start. If there's any issues, we can sort of flag it up and say, oh, there's this issue or that issue to you guys. Generally, they look pretty good, and from that point we form a model. We design it on screen and 3D print the model. In terms of the in digital, what we're looking for is clean scans, because sometimes you can have doubling, or you can have like holes or things like that within it, or the scan bodies not being looking correct. And basically, it's a workflow where the system recognizes certain scan bodies, scan flows that you put into the mouth, and that's what connects our systems with yours. And we print the model and then work on it from there. I know you use Trios. Yeah. How did you find that?
All right. Yeah, actually, I'm going to tell her. Yeah, I forgot the dongle, which I find a real pain in the backside, because if it isn't bolted to me, then it tends to be forgotten on occasions. So I turned up at a practice and I'd forgotten the dongle. I like Trump, I blame somebody else. Somebody else's fault. It's not mine. But it was mine. I'd forgotten the dongle. And so I had to use their iTero machine, which is another scanner for anybody that's listening. And I didn't like that. I didn't like that at all. It was I'd used it a long time ago, and I find it very clunky, very chunky. And the way that it kind of scans and then says, hang on a sec, let me just catch up. And then you scan again, and then it kind of says, well, yeah, okay, I've got that bit. Whereas with the Trios, I just find it a very smooth sort of scanning process. I think that once you get used to it, you can pick up the errors that you guys have mentioned by flicking from color to mono. And I think there's 1 or 2 cases really early on, you guys sort of identified where there was a little bit of an issue. And I didn't see it until you pointed it out. And then I think you kind of made me realize some of the errors that were happening on some of the scans. If it's wet, or if there's a bit of steam on the scanner, you get issues, or if it doesn't stitch properly. And I think that a lot of that now has been fixed, I think, with the updates they're doing. So yeah, I actually I can roll out a scan in less time than it takes to do an impression.
Yeah.
I just find it phenomenally better for the patient and for me. I don't like taking impressions now, but I mean, I was talking there, Will, about the full arch. I don't think that, for me, going digital yet is the right thing to do with the full arch. That's just for me, the full arch cases. I don't know about you.
Yeah, I mean, that's what I mean, it's interesting because I'm sort of digital dinosaur, sort of looking from the outside in. Just a dinosaur, just old and decrepit. But I'm also probably not like one of the, you get new adopters, people who are going to buy the first of everything. I'm sort of iPhone 5-ish, so it's kind of like that's my sort of analogy on where I'll come into the marketplace, So in some ways, you guys, if you were selling it to me from a dentist point of view, and maybe from the technician's point of view, perhaps Carl, sell it to me in terms of like why you wouldn't go back to impressions and things for smaller arches,
for smaller
smaller segments.
For smaller segments, I think, in my opinion, the accuracy is better. So I've not had an issue with the accuracy on them at all coming to the fits, not only with the actual fit interproximally, but also occlusally. So I have, not that I've got many issues with the silicone impressions. There's a lot of mess, I think, with the silicone impressions, and you just get rid of that. That's all gone. I'm not waiting for a perfect mix or anything like that. I don't have to wait for it to set. You've just got the scan. I can look at it there and then, and you can actually magnify it and have a look and see whether you've got any errors on it. I think the communication between the lab is instant, so you're not having to wait for it to be picked up, the post, especially with what's going on these days, and then waiting for it to be cast up and then fed back if there's any issues with it. It's almost pretty much within sort of quarter of an hour or half an hour, depending on how quick these guys can get access to what you've posted. But the scanning time as well, I think once you've picked up on the scanning time, it's less than it takes for the impression material to be mixed and set in the patient's mouth. I think from a patient point of view as well, it's phenomenal because
more comfortable.
To comfort wise and to actually show them as well. This is what we're doing when you're doing the consultation, the pre-scan, and then when you're actually scanning as well. So I couldn't go back. I don't think I wouldn't like to go back at all. For me,
and are you using it for workups as well? And are you merging it in with your CBCT scans?
Yeah, I love that side of it. So planning wise, it's on a different level. So you've got your study casts, you get it on your CBCT, merge them together in the software. So I'm using a combination of, I'm trying, if you're listening 3Shape, I'm trying to use Implant Studio, but hopefully we'll get there. But Co-Diagnostics and Blue Sky Plan. So I'm using either of those planning bits of software and then putting the virtual tooth into the position and then putting the implant onto the CBCT and planning it that way. And again, we're looking at doing a few guided, but we talked about that previously. So yeah, I absolutely love it. I'm probably not as late an adopter as you, mate. But I'm not an early adopter either. So I kind of wait a little bit, but I'm probably early-ish adopter maybe. I like gadgets as well, so that ticks a box.
And what's the learning curve like? How
when I'm in surgery, sometimes I'll do the first scan and then I'll pass it to whoever's supporting me and let them do the second scan. Not necessarily on where we're changing the scan bodies, but certainly on the patients where we're doing the study casts and things like that, on the nurses that are training up. That's how easy it is. So they actually watch you do your first scan and then they can do the second scan. That's how easy it is to pick it up.
Yeah.
In terms of sort of picking up the issues that you can get with the actual scan bodies and things like that, as Steve said, I don't think you get many issues. It's sort of self-diagnostic in a lot of ways. So if there's a problem, it kind of tells you. There's a big green patch or whatever, or it'll let the software actually say, yeah, you've done that really crap. You need to do that again.
And where are
technical word?
Yeah.
Yeah.
It's the way my software speaks to me. It's the way most people speak to me, to be fair.
Are there any hidden costs?
Hidden costs?
Yeah, well, there costs that you didn't anticipate when you know, as you get into it, like software costs and all this sort of stuff.
No, there's nothing that's hidden. I think the scan bodies are reasonable. They cost less than the impression posts. So that's quite nice.
Just make sure your nurse looks after the tips.
Yeah,
that's what I would say.
That's the hidden cost. That's the hidden cost, is eventually the tips wear out and the renewal of the license. So that's another cost you've got to factor in there. So if you're looking at these things, look at the license fees that they're going to charge on an annual basis, if they're going to charge a license fee for using their software. That's the cost I think you've probably got to be aware of.
Yeah. Steve, what would you say the with the scans that you get through, what would you say is the most common error for you guys at your end that you're ringing up clinicians about?
It basically, it can come from where people haven't gone in a steady motion around. So if they don't always give you the tuition. If you start on one side of the mouth and then the other, and then you sort of just go here, there, and everywhere, what happens is that the system's trying to map the last image with the next one and in an exact way. And if you move it around all over the shop like a magic wand, you can get some quite mad anomalies in there and holes, which if you then send them to us, our sort of system can't compute it because there's too much going on, and that's where problems can arise. They're really simple to sort out. It's like taking a good impression, taking a good digital scan is exactly the same. It's a skill that you just quickly go, oh yeah, this is it, and away you go. But it's all it is looking at what you have on the screen. I mean, the good thing about it is it's a big screen, so you can see everything. So if there are any issues, you can instantly sort of go, oh yeah, I can kind of see what that is. And I mean, the good thing is when you send it to the lab, if you think I'm a bit not sure about this, what's going on, you can literally say, can you have a look at this now? I've got the patient here. Yeah. And then it comes over instantly. So you can sort of instantly get that thing. You haven't got to wait for anything to be cast.
No.
That is brilliant. You can sort of go, oh yeah, that's bang on. That looks brilliant. Or what I'd do here is, and it sort of closes that gap, and you can sort of talk about it, and it gets you to where you want to be.
I've got to say, Steve, you are one of the most patient people I think I've met, because the times that you've rang and we're talking about some of the cases and we might try this or try that scan body, the time you take to explain, but not just explain, you will also point us in the direction of why don't you try this one though and that. I've met some people in my time, but you are so patient.
The problem is there's so many different scan body systems, all sorts of things to do with it, and it's constantly evolving. It keeps changing. So it's difficult when people first start with digital. It's just different. It's not hard. It's just different.
A new tool.
Yeah,
just got to work with basically.
Yes.
Say that again, Dan.
It's just a new tool that you basically just got to learn.
Yeah. What do you guys prefer? Do you prefer the digital or the old dinosaur approach?
Because obviously comes into the system and Steve can work straight onto it, and obviously go back to when you say you do your before scans. Basically, we can merge all that information in, and say if you did a temporary before and you've scanned that, and then you took your pickup impression with your scan, we can actually merge everything together, so you can go inside that temporary. So you got something from the start, rather than you've got to look at a study cast, you've got to maybe take formal seals, you've got to try and put it into a system, or you've got to try and wax it up. It is simpler. It is.
Have you guys noticed any difference in I'm sure you don't get many remakes, or issues between the digital and the sort of the analog impressions, the silicon impressions? Have you noticed is there a difference in the sort of, if you could say there's a comparison between an impression and a digital, would you say one's more accurate than the other, or you get more issues with the silicon than you do with the digital, or is it the same or just a different issue?
Obviously, I don't think you'd ever have an issue as such with the stone model, because obviously it's solid and everything's solid. You took a good impression. Obviously, the pickup copings, you screw them in, they're engaged. You then pour it in a hard stone, and so everything's not going to move. Whereas there are slight variables in a digital model, because obviously you've got to make sure you've put the scan body in place, and obviously they're just little PMMA things. Obviously, yeah, I've got some metal fit surface ones which are a lot better, but if you haven't fitted that PMMA down properly, because there's some of the issues we've had to deal with, haven't we? Where the scan body isn't quite in place, because obviously you can screw it in, but it's not in place, if you know what I mean.
Yeah, I do, because I've made that mistake.
Yeah.
So yeah.
And so you could go all the way to making the crown thinking you've put that implant in the right place, and it's not in the right place.
Yeah.
And you have to then also put the analog into the model once it's printed, and it's variable again.
So, I mean, initially when we first started, getting digital models correct took a lot of trial and error. You know, the analogs going into it's all settings within the system. At first, you can make the model and you think, oh, this is fine. And then the repositional analog won't sit in at all. You're like, oh, okay. And it's literally trial and error and printing them to get it exactly how you want it to be. And then the workflow works. But like anything that's new, to begin with, it's actually harder work. Whereas now we know exactly when things come in, we go, okay, this is the settings for all these things, and it works. But, you know, when you first get your 3D printer, it's not just press the button and away it goes. It doesn't work like that. You know, there's loads of times you go, why is it doing this? What's going on?
So go back to you, Carl, I'd say digital is better for us now. Okay. When it first started, I'd say now stone models, because it's easy, we know what we're doing, it's simple. It's just a learning curve. It's all just learning curves. Obviously, you've got to move with the times, and that's the way it's going. So
when you get your digital impression, are you then carrying on with the process of, say, designing a CAD/CAM abutment, and are you then doing hands-on porcelain work, or are you milling porcelain? How are you working the final restoration?
It depends on what the dentist wants. You can either have milled zirconia on like a tie base or a custom abutment style, if you want a solid zirconia, or we do zirconia which is then layered if it's anteriorly and there's lots going on, there's character that you really want in depth in there, or we do all one piece metal ones that are milled and then they're layered. So whenever we get an implant crown in, it plays an implant crown, but we tend to have a conversation with that dentist basically saying, what is it that you prefer? What do you normally get? What do you like? What are you looking for? Because it's not sort of one implant crown is not equal to another. Yeah. And with all of them, there are ups and downs to every single choice that you make. You can have, say, a Varia base crown with zirconia on, and there'll be no fracturing. But there is the possibility that it could debond. It's very, very, very rare, but that's the downside.
Yeah.
Where you have an all one piece metal one, which is layered. Obviously, that will never happen. But the interface has been fired.
Do you think there's still no substitute, especially with anterior crowns, for good old fashioned, hand-eye skill and
definitely.
porcelain?
Yeah, definitely. It looks different. It looks they look built in. They look more natural. Anteriorly,
like zirconias now, they've come on miles. They do look really good. Back to where they first started doing them, they're all one block colour, weren't they?
Yeah.
Whereas now you get them in stage, you get sort of tip shade in them, and they do look really nice once they're stained up. But layering porcelain, I don't think you're ever gonna beat, so to speak. Especially if you've got someone as good as Dave.
Hey, go Dave.
So what was it like? What was the effect for you guys during lockdown? When did you finally reopen?
Right, we locked down on the day they said lockdown, wasn't it? I'm forgetting it's Christmas next month.
That was March.
23rd of March.
I finished a couple of days early because I wasn't very well. I went particularly well. So
the 23rd of March we closed down.
Yeah, we did close down.
And then as soon as dentists could open again, we opened our doors in sort of stages. We wasn't all in here. We said to our customers, if they need us, we're here. And so it took a couple of weeks for work to start coming back in. And then, we was pretty busy. Obviously, because we're mainly implants and we're private work, a lot of the implants could have bedded in. So that was a good thing that all these dentists wanted to obviously restore their implants. So that was a positive with it.
Yeah.
But no, apart from affecting us, obviously it's tough. It is tough, isn't it?
Yeah, I mean, obviously it's weird, just not, you're so used to this, being busy, doing this, that, and the other.
Because obviously no one had been at work for 3 months. I don't know about you guys, but you suddenly forget how to do your job after 3 months.
These two have found it difficult to do a day's job. Is that correct, boys?
Yeah, we were shattered.
Yeah, we're still shattered.
Couple of hours, that's it.
Oh,
yeah.
Will, he's had a solid couple of weeks.
I know.
Yeah.
You'll be dropping off in a minute, Will.
I know, it's Friday. You can see I've cracked the beers open already. So
don't blame you. Don't
forgive
blame
me
you.
if I start slurring my words and try to fight everybody.
So, I mean, you said, Danny, it was a couple of weeks since the work started to return. I mean, really, that's not bad. I mean, it gave you, as you said, a gentle introduction, really, all getting back into work and having to do some bits different within your lab. But I mean, a couple of weeks, that's a good amount of time, really. It could have been a lot longer, really.
Oh, it could have been. Obviously, we do know some labs that have really been struggling. It's unfortunate. It is really bad, and obviously, it's
and obviously this. We're not sure what this will, whether this lockdown will make any difference. It seems to be less so in the dental industry.
Yeah, I don't think it'll make any difference regarding.
I'm grateful dentists haven't got to close again now, and we can just keep going. I think it'll be a bit slower. It won't feel like it was prior to first lockdown, but I think as long as the work keeps flowing, like I say, being private, I think that helps massively. But
we were in a practice. The reason why I say that it's good that it was only a couple of weeks, because obviously when the doors opened and practices could get back to work, not every practice did, which obviously could have a bigger knock-on effect to you, because the dental world was getting back to some kind of normal. We were actually at a practice last month, I think, Carl, and we were told that one of their local practices still haven't opened.
Oh, yeah.
So, that has a massive knock-on effect for you, because obviously you rely on those practices opening, don't you? So
that's it.
I mean, go on, sorry, lads.
And I think it's good, obviously, if you need to restore an implant, they didn't need all that PPE, they didn't need all that gear that they had to wear. So it was obviously just taking an impression, sending the job, and obviously
or a scan.
Or a scan,
Stay on message.
Will, they're working on you.
Stay on message.
I think you've hit the nail on the head, isn't it, really? Because you're looking at, if you've got to do a crown prep, in the most cases, you're looking at the old AGP and fellow time, which Will and I and Kate are experts
we talk about sometimes.
Yeah, we've got to stick in a little bit.
And
the practices have then had that knock-on effect of having to fellow that surgery for an hour or whatever time it was before they could go back in again. So obviously I would have imagined they would have stacked up their crown preps for when they were hoping that horrible, aerosol was going to get less lethal, and they were going to be able to reduce their fellow times, which has come down now to a more reasonable time. I don't want to go down this road.
No.
So have you seen a sort of slow increase in the number of non-implant crowns? Has that kind of been creeping up?
Yeah.
So your conventional crowns and on-lays and...
Yeah, I think that took about 4 to 6 weeks. No, probably when their tier dropped down, when we could... What did they call it?
It went from, was it 4 to 3 or something like
that? Because they do.
Yeah. And that's when they started coming in. But now it's pretty much the same as what it was.
Brilliant. It's good to hear.
So it's good.
Yeah, because one of the guys was sort of saying it was difficult for him to prepare when he was dressed like a spaceman. This is really hard for me to kind of do what I normally do when I've got all this stuff. I can't really see what I'm doing. So, they were quite glad when it had dropped down, because it was a hindrance for that doing your everyday work.
Yeah.
I mean, luckily for us in the lab, obviously it's quite sort of isolated, so we only see each other.
There's only 4 of us here.
Yeah. So, we don't have the same issues that you guys have in surgery, which obviously, the meeting people and all that sort of thing. So it is simpler for us.
Just a quick, talking about that and the issues and everything like that, the impressions that are coming in, Are they sterilised before? I know they are, but I'm just talking. So are they sterilised before they come? And are you guys doing anything different with those sort of wet impressions?
Yeah, we also sterilise our end.
Yeah.
Doubly sure. Obviously, they are marked on the bags that are sterilised. But
yeah. It's a prerequisite, isn't it? But that's another thing, Will, I guess, that you could sort of tick in the box of sort of
definitely.
scanning.
You don't have to have the model once it's printed now.
And with scanners, do they have some sort of covering, or they just have to be disinfected?
The tip is autoclavable on the Trios, and the Itero, you've got, I think that was a disposable tip with a cover on top. And
does the autoclave kill them? Does it eventually?
I mean, there's a little tip. If you put a bit of gauze in over the mirror, that protects the mirror.
Right. Okay.
But they wear out after a bit. I mean, it's going to, isn't it? That temperature. But it's it's a couple of years really. Yeah. So they've got a fairly decent shelf life. And they're not the tips aren't massively expensive.
Yeah. No, I'm just on that diving board. I'm on about my second bounce. Before I just go over. So and then it'll be a somersault, and I'll be all in.
And it'll all be digital.
It'll all be digital. I'll be a born again evangelical digital dentist. You're boring everybody. Be a proper digital nose.
I want to take the opportunity, because I know probably Danny and Steve probably won't, but I've got to say the service that DSD offer is seamless. I did just say how patient you are, Steve. Danny, I'm not saying you're not, obviously. It's just I spoke to Steve a lot more. But what you guys do, I mean, the relying that the work's going to be back at the practice on time, and because Carl and I aren't in one practice all the time, it's sort of added pressure to make sure there's an individual there to make sure the work's back. But with DSD, it's just like a given. Yeah. It's just like DSD, the work is going to be there. Your service really, really is fantastic, and I'm sure Carl will second that.
Yeah,
it's superb. I mean, that you're not afraid to tell me when I've got it wrong, which is great, because that's what you need. And we have that good thing.
It's definitely a good thing that technicians can do that.
Yeah, it's a good relationship, which is fantastic.
And there's been
some get on the phone.
Some little things where we've struggled a little bit to get you the information. So you've kind of said, try this or try that, and it's really helped out. And we've had some quite complex cases where your input's been invaluable in getting those cases sorted out. So I've learned a lot from you guys. So thank you.
No, I think it's basically you just care about what you do. I think care is a bulk of what we do. You mean we care what we send out the lab. We care about helping people. So
it shows.
That's how we've always worked.
It's getting the information. Sometimes you phone up companies like implant companies, and there's nobody to talk to. There's nobody who'll give you the info you want, and it's the most frustrating thing in the world when you're trying to solve a problem, because that's what we do. We're just solving issues, and what you want to be somebody when somebody asks you the question that you can answer, you give them the answer.
Yeah.
It's as simple as that,
I agree. Yeah. Well, it makes it easier for everybody, doesn't it?
Yeah.
Yeah. So, yeah. Well, we enjoy it. The last 5 years have absolutely flown by. Yeah. It's mad, isn't it?
So what do you think the next step is for you guys then? If it's 5 years doing this, you've gone from you've seen the digital stuff take off, you've invested in the CAD/CAM work and the printers and everything. Where are you guys going to go next, do you think? What's on the table?
Well, we invested in, obviously we've got implant studio as well, so we design guides and stuff like that. We are looking at another printer, a more, because obviously you can spend ridiculous money on these printers. We're looking for,
because obviously you get more digital impressions. Obviously it goes like that.
What are you going to do with a new printer? What's different about this one than the one you've got?
It'll just be faster.
Okay.
That's the main thing, isn't it? Faster.
Yeah, faster. And the resins, they are constantly evolving. The resins, the temporary resins, and that, the list of resins is growing. But again, it's one of those things where they put them in the marketplace and sort of they trial and error them a little bit. It doesn't. Nothing ever comes out of the box and it works. You have to sort of experiment with them. And you get the whatever new bit of kit it is, and you have to iron it out for a while before you realistically can use it.
Yeah, I know. You tell Will when he buys a new phone.
I'm going back to the Nokia, I think. The one with the little rubber casing, you know. Good as gold.
Why not, Will? Why not? Well, boys, I've got to tell you that's 45 minutes, guys. I know. But we've had it from Danny and Steve that they will come back and hop on the panel. So I've got them to write it in blood. So that's it, boys. You're coming back.
Committed.
Seriously, anybody out there, do not hesitate. Really seriously, use these boys. They are fantastic. Honestly, the communication, their workflow, honestly, please use them. They are really good. And no, I don't work for them. But they really are. They offer a fantastic service.
We really appreciate that. And again, thanks for having us on.
It's an absolute pleasure. Yeah, it was good talking to you guys.
It's not a problem. I hope you all have a fantastic weekend. Everybody out there, thank you. It's going to get a bit colder, so Jackie Frost will no doubt make a visit. All have a fantastic weekend.
Yeah. Cheers, everybody. Thank you all.
See you guys.
Bye.
Bye-bye.